anybody in the long gallery, phones must be on silent. It's not permitted to take photographs or record any of the meeting. Any apologies? None. So I literally am just going to skip through a number of items, members, because Professor Taylor has to be away at 3:15, so I'm going to move straight to item number 8 in our agenda, which is an oral briefing from the Department on the Elective Care Framework, Governance, Delivery and Outcomes. Can I refer everybody to the briefing paper and data sheet from page 3 of the tabled papers? Papers were previously considered by the committee, and some of those are from page 129 of the main pack. And then can I welcome Professor Mark Taylor, Regional Clinical Director for Elective Care, Lisa McWilliams, Director of Acute Planning and Performance, and Joanne Elliott, Interim Director of Elective Care and Cancer Policy. So, Mark, I've just outlined to members that you have to be away at 3:15, but the other two members of your team can stay on if need be. So, we've put you up the agenda to get in straight away, and just given the time constraints, can I appeal to members to be brief with their questions, and also to you to be brief with your answers. So I'm going to hand over to yourselves. We've got your briefing papers, but I'm going to hand over to yourselves just for some opening remarks before questions.
Chair, I have the opening remarks, if that's okay. So, Chair, members of the committee, thank you for the opportunity to brief you today. I'm joined by my colleagues Lisa McWilliams, Director of Acute Planning and Performance, and Professor Mark Taylor, Regional Clinical Director for Elective Care. I'm just going to very briefly cover our headline achievements to date on elective care, the funding position, governance arrangements, and the position looking ahead in 26-27. So reducing waiting lists has been one of our greatest challenges. The reasons are clear: rising demand, years of financial constraint, and a slower pace of reform than is needed. Against that backdrop, the Department's Elective Care Framework, published in May 2024, sets out a 5-year plan for a system that is sustainable, equitable and efficient. The plan covers service transformation, backlog clearance, productivity, workforce, independent sector engagement and patient communication. While waiting lists remain high, there's been a clear and measurable progress through the implementation of the Elective Care Framework, particularly in relation to reducing the longest waits. Since April 2025, we've delivered over 237,000 additional appointments, diagnostics and procedures. This exceeds the programme for government target of 70,000 additional treatments. We've seen reductions of between 76% and 99% in the number of procedures where patients have been waiting over 4 years. Overall, the number of patients waiting over 4 years for outpatient appointments has reduced by around 50%, and for inpatient and day case treatment by around 62%. So while the overall system remains under pressure, there's been real progress for those waiting the longest, which was one of our key priorities. It is, however, important to be clear on the funding position. While 215 million was identified in the programme for government and last year's budget, only 50 million of that represented new funding. 85 million was directed towards red flag and time critical patients, which largely reflected our existing pressures and commitments. The remaining 80 million had to be found from within the department's baseline. As a result, 37.5 million of that 80 million was returned to address the department's significant deficit, with a proportion available for wider capacity building. So the progress that has been achieved this year within very difficult constrained financial parameters and within significantly less new funding than the headline figures might suggest. Despite these constraints, the programme for government commitment provided us with a clear focus. This reflects the increased core capacity, targeted backlog clearance and use of independent sector, as well as improvements in productivity and efficiency. It's important, however, to emphasise that while activity has increased, demand continues to outstrip capacity, which is why our overall waiting lists remain high. Waiting list validation has been of particular interest to the committee, and as you're aware, there's been a considerable focus on validating the longest waits. Our waiting lists are dynamic. Patients are added and removed on an ongoing basis. While patients are continually removed from lists through their assessment and treatment, clinical and admin or other reasons, new patients are also being added over the same period. As a result, the overall size of the waiting list may appear relatively static, despite the significant underlying movement with significant numbers of patients both entering and leaving the list during the period. Validation activity supports delivery by improving the accuracy of our waiting list data and enabling available capacity to be targeted more effectively. And I know the committee are likely to have some more questions around validation, and we're very happy to answer those. I'm aware the committee today also want to discuss governance, and we can provide assurance that there are robust governance in place. Delivery of the elective care framework is overseen by our elective care management team, which is representation from the department, trusts, along with clinical leadership. At an operational level, our strategic planning and performance group monitors activity and spend on a monthly basis. There are regular performance meetings with the Trust and formal reporting to the Minister. As we look ahead to this financial year, the position remains challenging. The proposed funding for waiting lists set out in the draft budget is essential to allow us to maintain progress in red flag procedures and to build core capacity. We're very mindful, however, that the draft budget currently has no additional funding for backlog reduction. Despite this, work is underway to develop a new plan, and the Minister is clear on the importance of maintaining momentum, continuing to prioritise our long waits, build capacity, reforming service delivery, and improving productivity and efficiency across the system. So in summary, we have delivered significant additional activity and reduced some of our longest waits. This has been achieved within a very constrained funding envelope. Strong governance arrangements are in place, but sustained progress will depend on addressing the underlying demand capacity gap. We're very happy to take your questions. Thank you.
Okay, thank you very much. And your highlights are certainly some of the things that I expect us to explore. Waiting lists is an executive, or reducing waiting lists is an executive priority, and it's certainly a priority of every MLA in this building. I would assume our constituency office are continually being contacted by distressed patients or families of distressed patients, of people who are suffering on lengthy waiting lists. So in the work that you're doing, we wish you well and hope that you succeed. But we obviously have a role in this committee to ask questions which scrutinise how a substantial amount of public money is being spent, and if it's been spent efficiently. So hopefully we can get the balance right in that today. In terms of validation, so there are 100,000 validations were completed. So it's very difficult for us as a committee to understand exactly if the waiting lists are being reduced as a result of validation, or if they're being reduced because patients are having operations and treatment. So can you give us an equivocal answer to that question?
Sure, Chair. First of all, thank you so much for accommodating me today. And secondly, thank you for the scrutiny, because we very much welcome that. And it gives us an opportunity to thank everyone in our health and social care, because actually we're going to demonstrate to you today real activity on top of validation. So actual patients, because we often forget when we talk numbers that people are sitting suffering, and your constituents are a timely reminder of that. Validation in its simplest form is something we do all the time as clinicians. We're always triaging on the basis of need. But when you have long waiting lists, it is extremely important to ensure that you have administrative validation, which simply means 5 trusts, individuals on 5 different waiting lists. That same individual, that's counted as 5 instead of 1. Administration, where people are still on a waiting list but actually have sought treatment elsewhere. That needs to be rectified as well. And then when we look at all the clinical reasons, and I'm going to bring Lisa in with the granular detail and breakdown of that number you mentioned, is that when you're waiting 5 or 6 years for surgery or a procedure, you may no longer need that. It may not be still indicated, or more importantly, you may not want it. So if you haven't had any symptoms of gallbladder or tonsils or hernia in 5 years, do you really want the risk of surgery versus what is perceived as no benefit? So validation is extremely important, and what it is definitely not, is some way of artificially making our numbers look better, because that doesn't benefit any patient. And you're sitting here today with operational lead, policy lead and a clinician, who all want to see every single patient get that timely access. But Chair, if you don't mind, I'm going to bring Lisa in.
Yeah, thank you. Chair, the number that you mentioned, the 102,835 records that have been validated, they are targeted work, as Mark describes, to have a look either administratively or clinically. As a consequence of that, we have a validation figure of those patients who were moved, so we separate that from activity, so I'll give you those. So as a result of those 102 records being looked at and individual patients, and we have outpatient information, we don't have ins and days treatment because of coding, but the 102 relates to the totality of what I'm talking about. So the admin validation for outpatient removal is sitting at 42,992 and clinical is the 4,515. So they are captured as true validation. They have had no outpatient. We're not claiming activity with those. That's an exercise. So probably helpful if I then talk about activity and just give you that assurance. So we have a number of pockets of money which have activity ascribed to them. So the 85 million, which is the red flag and time critical, the 237 536, that is all activity. So we have a breakdown of just over 44,000 new outpatients, 11,000 review outpatients. I'm just rounding down. Diagnostics is just over 149,000. Treatments, so inpatient or day case, is 15,000, and AHP assessment and or treatment is 17,376. And that's activity that has been done through additionality in the trusts, or insourcing or IS, and we can attribute spend to every piece of that activity. So that's true activity in that pocket.
What was the total? Have you added those figures up?
237,
Okay.
536. That's a January position. We have unvalidated February, and we will still get March. So this, we're not at a position to give you a total year, but that is true additionality. Then we have mega clinics where individuals have been seen. So the April to January position for mega clinics, so that's an assessment and sometimes a diagnostic test. That's 8,474 patients, and that's only a part year effect, but it already exceeds what we did in the previous year, was at 7,034. And then we also have, as Mark has talked about, we targeted a cohort of patients for treatments explicitly. So either 4 years for some of the adults, and then we had different targets for the paediatrics, recognising developmental. So we have information that actually shows that movement, and Joanne's gone through some of the very high level reductions in that. But actually sitting alongside that, because some of that would have been validation, what we've actually captured is what was additional backlog activity, which includes those procedures and anything else that we have been doing. So the actual backlog activity for January is some 28,858, and that is, again, news, reviews, diagnostics, treatments. So we are trying to be as clear as true activity. And then we have primary care elective activity, which for the year to date is just over 12,000, with 10,500 of those face-to-face, and then 1,500 of those are remote. And there are gynae, our dermatology, our MSK, minor surgery, vasectomy. So that's true activity, excluding validation. So
I mean, that's good. I'm kind of going to jump on here because there's a number of questions I want to ask. So that's always very positive news, and we're delighted to hear that. This is a subject where it's a bit like a seesaw. When you read one table, the news seems great, but then the next table probes more questions. So, and I'm not arguing this isn't how it should be done, but I mean, what's happening here is that those at the 4-year wait are being dealt with first, which is appropriate. But what seems to be happening then is the kind of that number of people in the middle who are waiting 1, 2, 3 years is expanding. So whilst the activity is reaching those at the far end of the waiting list, as I say, which is ultimately very appropriate, the waiting lists aren't really getting any shorter, because that section of people who are still waiting a very long time is getting longer. Am I correct in that?
Well, I think, first of all, Chair, you're absolutely right that if our strategy was simply to look at the people waiting over 4 years, then all we're simply doing is looking at this cohort of people, the longest waiters, and actually forgetting all of those people waiting, let's be honest, totally inappropriate lengths of time. And that's why there's a multiple pronged attack in terms of the elective care framework. And just to say, I think it's really important for all our clinicians and administrators out there to recognise that despite the many pressures this committee are familiar with, there has been a sense of urgency. And that sense of urgency was facilitated by additional money, but with a focus on we have got to do all we can in terms of theatre productivity, outpatient productivity, in-house, insourcing, i.e. people coming in at nights and weekends, and then the use of the independent sector. So I think it's really important to say that yes, there's the 4-year waits, but the other area that we have been absolutely ferocious at looking at is levelling up any variance of practice. And I saw Alan looking through the individual trust breakups of numbers there. We are going through all areas of variance in practice to ask why. Quite often there are clinical reasons. You know, I am a surgeon that does 1 operation a day. Am I a very, very lazy surgeon? No, it's an operation that takes 8 hours, as opposed to a surgeon that's doing much smaller procedures. So I think the focus on the now, how do we build up capacity using the elective overnight stay centres? The example would be if you go in to an ambulatory unit today with gallbladder pain, I don't want you going on a waiting list. I want you on the Tuesday list of the next week to have your gallbladder done. So that is here. The backlog is here, and then the bit in the middle that you have referred to, Chair, is the bit that we are really trying to focus in on specialty by specialty, which is, do we need to see everyone in outpatients? Do we need to see everyone before they get the test? And do we need to see these individuals afterwards? So 1.3 million outpatient appointments every year in Northern Ireland. Are we sure that every single citizen is meant to be in those seats? We now have the wonderful opportunity with EPIC, patient-initiated follow-up, advice and guidance, enhanced triage, to deal with it. So in summary, if we were just dealing with a 4-year wait, you're absolutely right. We're just moving the chairs in the Titanic, but we're actually trying to look at all avenues.
In terms of focus that you mentioned a couple of times there, obviously red flag treatment needs to be a particular focus. It's certainly a focus of this committee. So Cancer Research have produced a report today. So it's not great reading, to be honest with you. We're still the weakest part of these islands. The weakest parts probably of Western Europe in terms of the longest waits for cancer diagnosis and treatment. Only 31% of patients are being treated within 62 days of a red flag referral. So, that's not really great. What is the focus in terms of dealing with red flag referrals, ensuring that we meet targets?
Yeah. I'm going to bring Lisa and Joanne in for that. Just first of all to say, cancer's on the rise, and that same report talked about a 14% increase. It also mentioned outlook and outcomes have improved. And I think it's very important to say that this is an access problem, not a treatment problem. And when you get to the clinicians that are there to administer the care, I stand very proud of the care we give to cancer patients in Northern Ireland as a cancer surgeon. Lisa?
Yeah, certainly. And just picking up at a couple of points. So the investment priorities for that red flag and time critical, and the time critical component of that is your cardiac surgery, some of your vascular work, but in the main it is the red flag. So a lot of the investment is about speeding up access to diagnostics, the use of the rapid diagnostic centres, and actually having more timely diagnostics, because with the 14% increase or increase in instant, we actually have a pick-up rate of about 3% from all referrals. So the referrals are also substantially higher. So the actual diagnostic component is really important. So we are, and Chair, you'd asked a question in your commentary a little bit about what's happening in the middle, those routine and urgent. So by tackling additional diagnostic activity, Yes, our red flag CTs waiting more than 2 weeks has reduced, that wait has reduced by 23%, but MRI and non-obstetric ultrasound for all categories have reduced. So MRI waits are down 18%, despite an 8% increase in demand year on year, and non-obstetric waits are down 14% despite a 4% increase. So we're really targeting diagnostics. There are lines of investment at specialty level as well, including demand management actions. So, for example, with dermatology, we are investing in additional CNSs, clinical nurse specialists for dermatology, but also in an AI tool which should actually see 9,000 suspect red flag referrals that get into the system actually not coming into the system, because the AI technology is so good that it would put people's minds at rest almost immediately. So we're investing in all of those, because actually dermatology is a really good example. The sheer volumes, if you could take 9,000 out, those people who absolutely need to be seen can be seen in those sort of straight to test, those straight to biopsy, as opposed to a very long wait. So we have current investments in the 85 million that are in that scopes, diagnostics, and then examples I've talked about dermatology and gynecology, but there's also general surgery investments, urology investments. A lot of it is the skills mix, to be smarter with what we have, and actually be clear. Even in our resourcing. So urology is a really good example of where we have invested through collaboration. So urology is a good example because we have regional scopes being done in our day procedure centres, which includes urology, but we have South Eastern Trust who do our laser and aquablation, and they do that for the region. Southern Trust do stones for the region. Belfast have the robotic for the radical prostatectomy, and then the West do penile cancer, because actually by doing that, everybody on those pathways can be seen in a more managed way. So really good, important collaboration across the system.
And that's really good. And Professor Taylor, you talked about when you get into the pathway, you get a really good service. And I mean, I would totally concur with that. In terms of cancer, for example, and obviously the earlier you get diagnosed, the better chance you have of success, and probably the more cost effective the treatment is. Screening and diagnosis is obviously vitally important, and I probably could pick any type of cancer, but I'm going to pick bowel cancer because the age for screening here in the north is 60, it's 50, across in Britain it's 57, I think in the south. So we're an outlier in relation to that. I'm not sure, in terms of waiting lists, if you can diagnose people earlier, then treatment is less complex and it saves, and you're less in the waiting list. So it's obviously, in my view, would be much more efficient if people of bowel cancer and all kinds of cancer were being screened earlier. How can the department rationalise screening at 60 and not being reduced?
So I think first of all, and I'll bring Lisa or Joanne in on that. I think first of all, Chair, the management of cancer, as you know, is preventative, early diagnosis and successful monitoring after, and all of those are important. So any one cancer we could choose today, there are so much work we need to do in the pre-operative and the neighbourhood and all the reset plans that have already been described, and then obviously in the diagnostics. And one of the challenges is that we're now seeing a dramatic rise in the number of requests for CT scan, okay? And that is one of the challenges where we're even looking with the imaging board at ways of, is it appropriate to get a CT for everything? And I mean in the unscheduled environment, there are conditions that don't need a CT, but we seem to be in a world now where it is CT. And that in a way is kind of robbing Peter to pay Paul in some ways. So we've got to be clinically specific in the diagnostics that we're using, and a bit like outpatients, we've got to use them in a limited financial world with a limited capacity and a rising demand. We've got to use them much in a better way. To the bowel cancer and the screening, there's absolutely no doubt we are behind our colleagues in the United Kingdom. But any one particular subject today will come to the same conclusions. we have a finite budget, we have a massive backlog, we have the now to treat, and yes, we've got to think of those earlier diagnostics that might save us money down the line. Absolutely agree, but more importantly, save patients down the line.
And just, I suppose, to come in on that from a policy perspective, as Elisa has alluded to, the elective care framework, considerable focus on the cancer red flag through the funding that's available there. Alongside that, we also have our cancer strategy, and there's a huge infrastructure that sits below that cancer strategy in terms of clinical reference groups for tumour sites. It's very clinically led and driven, so there's a huge volume of work that goes on sitting beneath that cancer strategy to drive that forward. And then aligned with that, we have our public health agenda as well in terms of our screening, our prevention, our messaging. So it's not just sort of cancer seen in isolation, it really is an umbrella.
Yeah. And in terms of just the specifics, with all that work, is the department going to consider reducing the age for screening with the example of bowel cancer?
I don't have the answer to that question at the moment, I'm afraid.
Okay, moving on, because you've raised, probably leading into my two very quick questions. You talked about value for money and cost. So obviously the executive have given an awful lot of money to reduce waiting lists, and some of that is being spent in terms of the independent sector, which I suppose we're in a needs must scenario. But I was sent a job advert just prior to Easter from I don't want to mention it too specifically, but it was a private clinic here in the north where they were advertising for a consultant, and they were offering 400,000 was the salary, and I nearly fell off my chair. So I suppose my question is, are in terms of the efficient use of money and also dealing with waiting lists, have we got the balance right here in terms of sustaining our NHS where patients can access the treatment they need free at the point of delivery, and not funding an ever-expanding private sector where we reach a tipping point? I want to be assured that what we are doing and that money that we are spending is being done sustainably to protect our NHS as well as our patients.
My one line, and then I'll bring Lisa in with the granular detail, is the whole emphasis of the multi-pronged attack to dealing with our waiting lists is that in-house is much better for a multitude of reasons. Same staff, working conditions, looking at productivity, efficiencies, all of those, early starts, late finishes, etc. And then using that same staff for overtime. There is no doubt that when you have the backlog of the waiting list that we have accrued over a number of years, that you need all the help you can get, and that's where the independent sector have been coming in terms of those long waits. But actually, we're using that as also a model of how do we bring about the same types of efficiencies that you see in the independent sector, but within the NHS. That's the goal. And the second issue, Chair, is that unfortunately we're in a market where you can easily go to the south of Ireland as a consultant and earn 2 to 3 times the salary. Our waiting list reimbursement scheme was hindered by increasing tariffs in Southern Ireland, so it prevented those going down to utilise it. So that competitive market is there, and yes, independent sector providers putting out these ways of attracting staff, that causes us concern, because we want the staff who all were brought up in the NHS and stuck to the core values of the NHS to continue to deliver in the NHS, and that we are actively and constantly looking at ways of innovating our staff to continue to deliver for us. Lisa?
And all I would add to that is, because a lot of the actions that we've been taking is we have a desire to build the core capacity, so that can't happen overnight. So we are continuing to use funding on a short-term basis to target backlogs or to continue to buy capacity. But in every, and my team is responsible for managing that budget and making those assessments and doing the allocations and monitoring the performance. So we always look for in-house additionality. We always then look for in the insourcing, because there are tiers of cost involved in this. So have we exhausted the potential of a company coming in using our facilities because we don't have the workforce to match the facilities that are vacant normally on an evening or a Saturday or Sunday? And then the third call is the IS. But even with that, we do a value for money assessment, and we have refused to send patients out because we are unwilling when the differential is so different from what we are prepared to pay. So that, now what we are doing and what we had hoped for with some of our conversations, our buying power is easier with multi-year budgets, because then you can really drive NHS tariff, because you give a certainty of volumes, but you really try and make sure. Now, we have been having a number of conversations with our IS providers about, can we talk about principles of working? So where possible, don't be poaching nursing or surgical staff. Can we work together? Can we work together on training? Is there a research option with industry and some of these private companies that the HSC therefore benefits from it? And very much one of the principles is, can we be as close to NHS tariff as possible, so that, so it does reduce the profit margins. Those conversations are much easier if you were negotiating a 3-year contract, and we're not able to in the absence of a multi-year budget. The IS we will still have to use, but we are trying to move that balance with every bit of core capacity that we're growing. Should squeeze it. Now, there will still be, as Mark says, there's a lot of learning for, and they wouldn't thank me for saying it, but some of the procedures they can do in more of a factory sort of chain run through, which is not always possible with the case mix that we have in the HSC. But there is learning from working with the IS. But certainly, whilst there's a commitment and acknowledgement we need to use them, we don't just willy-nilly accept the highest tariff, because that's not good value. We would prefer to look at our NHS England, Scotland, Wales colleagues, which unfortunately means patients might need to travel, or the teams might come to us, or we do have a number of contracts with ROI because of that value for money for assessment, and that is the model that we're approaching.
And an example of that, Chair, is the breast cancer triple assessment and the waiting lists, and when it became that single regional waiting list. So apart from our own clinicians, we have clinicians coming over from Forth Valley in Scotland to add to the capacity to try and meet that demand, and that's using in-house, but using our colleagues, and the same in terms of an all-Ireland agenda. We had the most fulfilling paediatric gastroenterology. Every committee member will be aware of PEG tubes in children and babies, and the difficulties of paediatric gastroenterology, and Minister and I had the joy of actually an all-Ireland agenda, where now our paediatric gastroenterology colleagues in Dublin are looking at even sharing the rota here in the north, are looking at how they can allow access in Letterkenny, Donegal, because that's a long way to Dublin. So that kind of north, south, east, west is all in the mix, but I hope we're demonstrating that actually certainty is what we need, and one of those certainties is the budget, is the 80 million that needs to be ring-fenced to add to the capacity.
I had that on my list of questions, but I've run way over my own time, so no doubt some of my colleagues will picking that up. Danny?
Thank you, Chair. Do you want to expand on the 80 million that needs to be ring-fenced then to continue this capacity, just picking up from what the Chair was saying?
Yeah, so look, as a clinician, it's always wrong for me to make bold statements about money, but to say that obviously we're here today with an elective agenda, and that elective agenda is dealing with waiting lists and the programme for government. Mm-hmm. And I suppose in the absence of a budget, there is still some uncertainty. Obviously, we know from last year, Lisa's articulated the initial 215 million, and where the earmarked 80, rightfully so, was needed to manage other pressures. And I suppose where we are at the minute, the 85 million recurrent will be for time critical and red flag, but the 80 million needs to be, in my humble opinion, ring-fenced, so that we are able then to add to the core capacity. And I suppose that's the uncertainty at the minute in the absence of a budget. And again, it's, we have constantly as clinicians been saying the more we've got the recurrent budget, the more we can plan recurrently, because this start-stop momentum, any impedance of progress will be felt in our waiting lists. They will go up again. We've seen that in the history of our waiting lists. So I suppose the plea is to ensure that we are able to continue the momentum.
Actually, that was where I was going to go with my question. In a way, just in terms of recurrent funding, how sure are you? How sure do you need to be that we are able to maintain that level of funding, that you're able to get that so you can have that additionality in the core growth? Not sure at all? Or?
I think the position is we need approval of the budget as soon as possible to enable that money to be invested as we have envisaged in the elective care framework, and to maintain and build on that momentum.
If that doesn't happen, what's the impact on the waiting list work?
And if I can come on that, because from the 80 million in year, we did spend 6.5 million last year, and there is a recurrent tail of that, which is just shy of 15 million. So we use that money. So with the 80 million, we only slipped the 73.5 back to central, and as Mark has articulated, that aided core pressures, but it also enabled us to a contribution to pay awards, avoiding strike action, which would have reduced activity. But in that, what we did do, we did have a profile of 6.5 million. So we have protected the primary care elective, as I talked about, the 12,000 patients that went through the primary care elective pathway. We invested in pre-op assessment, because actually having enough patients who are ready for surgery at short notice is one way of countering late notice cancellations of patients and do not attends. So we deliberately focused where we knew we had the ability to spend money. We have invested in the phlebotomy hubs, so not everybody has to come to an acute setting to get blood tests. That can be in your local health and care centres. And we also invested in training. So the training commitment from the elective care framework is by March 2027, so the end of this financial year, we would have committed to an additional 25 training posts. And there is an element of, not all 25 of those they'll not all need full consultant salaries paid, because there will be attrition with retirement. But there is a profile who are absolutely additional trainees for additional capacity. So we were already profiling through the 7-year spend for some of those. So last year we invested 7 anaesthetists. So that also came out of the 6.5, and then the 2 schemes with our third sector partners, the Waiting Well initiative and the cancer charities grants, came out of that 6.5. But the full year effect for the 26-27 year for those, because the training numbers are now an additional 28 on top of the 7. So they are an additional 28 trainees, where we have single-handed practice of vulnerable specialties. So it's the radiologists, it's urology, it's general surgery, it's paediatrics, it's haematology. So that has a bigger cost, because there's a substantial more volume. And then next year we also intend to have an additional 25. So we are going to far exceed the elective care framework training numbers, because we have to grow. We can't depend on attracting from elsewhere. We need to be able to grow our own trainees, and then we have to try and hold on to them at the end of training programmes. But we also used the 6.5. We had 3 trainees coming off the training programme who would have gone elsewhere in very vulnerable specialties. So 2 oral surgeons and 1 oral medicine consultant. So we employed them straight from training programme without any risk of them getting a better offer anywhere else. So we used that 6.5, but because the likes of those posts, it wasn't a full year that we were paying for their salaries, and we're paying a full year, that is where we get to already a requirement to spend 14.9. So that's the recurrent from that 80. And then the absolute desire is that we use the rest of the money for core capacity. So making sure that we can do long waits and the red flags, and do the people in the middle. But it does require that budget certainty. And then whilst we were putting that recurrent capacity investment, you would use the money non-recurrently to do more waiting list additionality non-recurrently for that backlog. So the desire is absolutely to have it, but it is subject to those discussions.
And I think, really important point, Danny, is when we have money, when we have urgency, and when we have the ability to max up on the ground. We deliver 262,773 episodes, or 237,000 episodes, sorry.
My numbers person.
Just as well I'm not in charge of the budget. And also, and then whenever you look at name procedures, colonoscopy down 100%, paediatric squints, lap choles, tonsillectomies, primary hip, those are all successes, but the bigger success is that in 10 years from now we're not sitting going over the same thing, that we have these horrendous waiting lists and we never planned for the future, or that we didn't plan the capacity and the different ways of doing things. And it's the same theme. We used to do it all this way, but we don't have the luxury of that now, with financial burdens, increased elderly population, rising complexities of treatment, the burning platform of 2016. So that's why every single strategy has to be that's the right person. Regional diagnostic centres to get rapid access for the cancer patients, the vague symptom pathways to get rapid access. All of these things are in the mix.
And that's the hope, is that we get to a certain point whereby demand is actually be able to be met by non-additionality, and that you're able to just cope with demand that's coming in, and people are able to get timely treatment in a timely way. When you say 10 years, is that the...
Well, I think for any patient listening, time is, one day is one day too late, and I think every part of the world is trying to deal with that imbalance between rising demand, which in a way is a celebration, because we're all living longer. We're going to double the population of those living over 80 by 2050. So that's a celebration on one hand, but with it comes a real struggle around how to keep meeting that demand. And that's where I can't say today, and I think it would be wrong of us to say today, that we're ever going to get to the stage where we're able to match the whole demand with the capacity on the ground without the need of help. But we've got to be sure that we're going in the right direction. And for the first time, and I suppose my disappointment recently was, for the first time we're seeing those first outpatient numbers drop. Now that's dropping with constant people being added every day. My colleagues up and down the country are seeing people and referring people in for outpatients every single day. But with that urgency of activity, for the first time in a number of years, the official statistics are starting to show it down. And I would love, I suppose, in Northern Ireland for us to recognise some of the success for all those people that are spending extra hours at night and weekends doing the work.
And can I just say, I'm very aware of the extra work that is being done, and I know every day there's great work being done in the NHS that maybe doesn't get the celebration that it should. And certainly when people do get the treatments that they need, the reports that we get from constituencies that the care is excellent. I do know lots of constituents who are on waiting lists for long periods of time, and that are suffering, in many cases getting worse. A lot of them are being driven into private medicine, spending a lot of money, and we can see private medicine booming in Northern Ireland. We're seeing new hospitals being built, we're seeing huge clinics that are really, really busy all the time. So people are spending huge amounts of their financial resources on accessing healthcare because they can't another way. But I am reassured that things are starting to change here. I do want to ask about validation. I find this very, very complicated, and I know we've asked questions as a committee about it. And in particular, how can you reassure patients who have been validated? What reassurance is there that they no longer need treatment? If you're on a list for a surgery, I know you had mentioned a couple of examples there, Mark. Why would they not need it? Why would you not need a tonsillectomy, a gallbladder I can't remember the other example that you gave.
So, a great question, and it's really important, first of all, to give reassurance, and that is no administrator or clinician is in the business of wanting people to be artificially removed off a waiting list if they need an intervention. But the difficulty, and it's unique to having these really long waits, okay, and they're all unacceptable. And Danny, every single day we're conscious of the people waiting and waiting and waiting and getting worse and presenting into unscheduled care and the burden that that's placing, which this committee are aware of. But if you're booked for a procedure or an intervention and you've been waiting for a length of time, that in some individuals, and this is the small number of clinical validation, okay, administrative validation is simply one thing, making sure the list is an accurate reflection of what we think it is. So in other words, that Mark Taylor doesn't appear on 6 different lists and is counted as 6 people. Or that Mark Taylor and I should say that nearly 6,000 people had actually passed on, but we're still on a waiting list.
As outpatients.
In terms of outpatients. So
6,000 people had died while they were on a waiting list.
We're still waiting. In essence, the system was trying to get them into an outpatient environment.
They never got the procedure that they were on the waiting list for.
Well, not necessarily. That could be outpatients for many, many things, and actually may well, and most of them will almost certainly have passed on for other reasons, for the very simple reason is that if you take very, very sick for whatever condition you're waiting for, you don't sit waiting until you're called to come in for the procedure. You go to unscheduled care, and that's why we're seeing the pressures in unscheduled care. And to the critics that say, why would you put programme for government for waiting lists? Well, actually, the waiting lists are a symptom that will further burden unscheduled care. We need to deal with them in the here and now.
And primary care GPs as well.
And primary care as well. So GP, constant contact. Can you ring in? Can you see where I am on the list? When am I going to be having that procedure? But back to then, there is a group of individuals, and this is a clinical engagement. This isn't that I or my colleagues sit in isolation looking at the records and then say, Mrs. Dodds is coming off the list, but I'm not engaging with her. This is where the mega clinics have come in, and many political representatives have visited the medical clinics. That's a consultant anaesthetist, a consultant surgeon, and senior nurses. And you come in with, say, a hernia, and you say, I'm now 81. I've been waiting 5 years for this hernia. Inappropriate, wrong, but it's not giving me any more problems.
Why inappropriate? Why wrong?
The weight is wrong.
Oh, the weight is
the
wrong.
weight is wrong.
Okay.
But the inappropriateness then would be to say, well, it's given you no problems, we're going to put you through an operation where there may be complications. Or if you have tonsils in a child, you may well have outgrown your tonsillitis and no longer need your tonsils out by the nature of that window of opportunity. Now, these are small examples, and sometimes we are seeing in the breakdown patients seen separately but for the same condition, transferred to another trust, not required. Patient no longer wants, so patients are quite happy to say, I don't want that intervention anymore. As long as the clinician's in agreement, that's where the validation comes.
Just as a quick question, are the patients always told? Is there always contact with the patient and they're told, so they're always informed that they have been removed from a list?
So in terms of clinical validation, that's a two-way process. The clinician and the patient are together. In terms of administrative validation,
There are cohorts where the administrative validation has resulted in, despite repeated attempts, no response. So the GP is therefore advised that due to the admin process that a patient is being removed, so the GP is advised and the GP has the mechanism back in to say, I'm unhappy, or you've been sending information to the wrong telephone number, they've updated the system on ours and it's not updated through. So there is a cohort in the admin, particularly for the admin outpatient, that there's a non-response despite repeated engagement to actually make contact with individuals. But there is that GP is advised, the patient will also receive correspondence to indicate they've been removed, with the information to contact back in within a window. But there are patients that are not responding to the admin process, and it would be wrong of me not to indicate that there is a cohort of those patients that are removed.
Some people may not know that they have been removed.
Well, they will then get correspondence saying we have removed you because we've attempted to contact, but the GP is also advised, because even if they changed address, the GP should, so that there is that fail-safe, and then there's the loop back in. But that's on the admin for outpatients as opposed to for treatment.
Yeah. And the clinical validation.
And clinical validation has to be more engaging.
And again, I suppose, don't forget, Danny, as we progress with EPIC, the patient-initiated follow-up, putting our patients in the control seat is going to be helpful too. So I want to come back and see Dr. X or Dr. Y because I need to, not that it's just the default.
Okay, need to move on to others. Dan?
Yes, thank you, Chair. And first of all, I do want to say thank you, because I think while Northern Ireland still, I was looking at these figures this morning, has over 500,000 people waiting on a first consultant's appointment, I think most of us are heartened that this is an issue that at least is being grasped and being dealt with, albeit that there is an enormous amount of work still to do. So I do want to say thank you. Now down to business. I have no idea whether you have the same sort of paperwork that we have, but I noticed on page 180 of the pack that I had, which is a response on the 13th of February 2026 to the committee, that there is a breakdown of total patients that have been treated, and the current update, and I think it was as of the end of November 25, so it's not completely up to date.
You just won't have that by way it's Southern Trust to the committee.
Yes, so it actually says that the Belfast Health and Social Care Trust had 55,000 odd patients, Northern 31,000, Southeastern 54, Western 27, but the Southern had only 18,543. Why was that? No ideas.
We might need to see the information. And
is this validation,
or is
Dan, or is this active?
No,
treatment?
it's actual. It's further to the request meetings, including a breakdown. Please make an update on the current. In 2025, recurrent funding was allocated, and these are the treatments and diagnostic tests that have been delivered, and the breakdown of the activity by trust. And the breakdown of the activity by trust shows that the Southern Health and Care Trust, by a long margin, was the poorest. It's fine if you don't have it now, if somebody can come back to me, because obviously the Southern Trust is the trust in my area, and I would just like to know why that information is as it is, and so on. And I think that is quite important.
We'll share that information. That was we wrote to the trust and got that, but I'm not happy to share it.
Happy to come back.
I'm actually really happy because variance is one of our roles within ministerial direction. So, and I think it's important, Dan, just to say that sometimes the number looking like an outlier may not necessarily equate to poor performance or not active activity, etc. And as I say, because we're not comparing apples with apples in many cases, but again, there's a combination of reasons for variance. One will be workforce. So if you were looking at gastroenterology in the Southern Trust, where we know we've had a major problem with our workforce, then you will see an anomaly compared to, say, Belfast with a fully active multi-purpose gastrointestinal service. So there are nuances around each specialty.
And I know that there's an action plan in place to deal with that in the Southern Trust, and I'm very glad to hear that. I don't shy away from those kind of difficult issues, but it's an outlier by a long way.
And it may be, I'm sorry, not having seen the detail, but it may be that actually we transferred Southern Trust patients to one of the IS contracts if it's for additionality, that the other trusts are holding the contracts so that patients are not disadvantaged. But I'm happy to have a look and see if we can come back. Sorry.
The other question I wanted to ask really around, so the biggest reduction has been in endoscopy sort of treatments and facilitating that initial investigation. But I think I've asked almost every trust that has presented to us so far, how many of those patients have proceeded to treatment? And that information does not seem to be available, in that we don't have that full pathway in Northern Ireland. So why do we not have it, and when will we get it? Because we were told when we got Encompass and all that everything was going to be amazing and we were going to be able to, you know, tap a few buttons and this information would fly off the shelf to meet us. But I think it's really important. I mean, it's amazing that we've done so much in relation to that, but how many patients have proceeded to treatment and have been able to access appropriate treatment? And I can't find any information that helps us with that at all.
And certainly we can come back to the committee on that. Suffice to say that when you're looking at endoscopy, that is the treatment in the largest number of cases, particularly if you've been waiting 4 years. So if you've been waiting 4 years because you have heartburn for a camera test, or you've been waiting 4 years for mild gastrointestinal symptoms and you have a colonoscopy, in the majority of cases, those diagnostics will be the treatment. You'll either have a biopsy taken and tablets, or you'll have, in the majority, the recognition that thank goodness it was normal. And if not, again, that's why I say that an individual with illness doesn't sit in isolation. Our GPs know it, our EDs know it, that if I had a colonic problem and I'm on this 4-year wait, but I start bleeding, I will seek help. And that's the difficulty in looking at numbers in isolation. But the question you're asking, Diane, is a very important one, which is, look, if you're having a cystoscopy, how many go on to need something done with their prostate? If you've had an OGD, how many go on to need surgery?
Yes, and how many have accessed the surgery? So what I'm really trying to understand is, so we don't have what in England and Wales they call the full referral to treatment. Knowledge and pathway and information. So we have no way of knowing how many of those patients, as you say, the treatment might be relatively simple, and a lot of those patients may require no treatment at all, and so on. But there's no idea of that in any of the information that we're given. So what I want to know is, if they've had their procedure, do they just go on to another waiting list? Or do they actually get treatment?
And I think what you're asking there, Diane, is, you know, and we would have used that for our cancer tracking system that we used to have prior to Encompass. We would have, you know, you would have captured closed episodes because the patient is no longer a red flag because there is no indication that they need to continue on that pathway. And what is happening is we're working through the process with the Encompass and Epic build is to replicate all of those previous reports. And some of them are taking longer than they should, because you're absolutely right. We need to understand which ones are closed episodes, as Mark has described, because your definitive treatment is the biopsy that you've had and the pathology says there's nothing to worry about, or you get a medical intervention because actually, depending what it is, it can be treated with drugs as opposed to surgery, or actually there's nothing to be worried, or it's closed because there's nothing to be worried about. But actually it's how they then continue on that diagnostic pathway, because the scope will not be the only investigation.
But Lisa, what the point I'm making is that we still don't know whether people have had their diagnostic test, whatever that diagnostic test is, and actually then accessed appropriate treatment.
Yeah.
I accept that the test might be the only treatment they need, but many will require further treatment. Do they go on to another waiting list, or are they just, what happens to them?
And I think it's a really important point, but there is a subtle difference between those waiting to see a clinician, whether that be a nurse, an allied health professional, or a doctor, and when you are then in and you have done the diagnostics, you now know that person. So if that person was a cancer, you're not going to put them onto an elongated waiting list. The difficulty and the people I always worry the most about are those we don't know about yet. When you, and we talked before about access, but when you are in the system, so the diagnostic OGD, the diagnostic cystoscopy, the diagnostic colonoscopy that you've waited for, if I'm doing that today and I see something that is critical, time dependent, I now have ownership of you as a clinician. I'm not going to put you on a situation that is giving you harm, and that's the moral distress that every clinician faces at the minute with these long waiting lists. Is we have a set of skills, we can do something, but the system is struggling to meet the demand. So just to give you some reassurance, Diane, I think your question is right about the pathway. We need to know every single person and what they need when they've had the diagnostic. But when they've had the diagnostic, they're known to us, they're known to the system. And, you know, if it's time critical or cancer, even with the reports today, no clinician's going to stand over that because they've suddenly become the advocate for that individual.
Well, just when we talk about cancer referrals, so I've asked about this many times, and I'm going to ask about it again. I mean, only I looked up the latest stats, only 29.5% of cancer referrals, of those referred for cancer, actually started treatment within 62 days. And that compares with 80% in the rest of the other nations in the United Kingdom. And only 5.5%, a reduction actually from 6.8%, of women with breast cancer were seen and with a consultant within 14 days. And the target time for that is 100%. So, and I accept that we are experiencing a rise in cancer cases. I accept that. But these figures are abominably low. They really are incredibly low. So is the elective care framework failing cancer patients, and should we have a priority targeted plan to actually deal with those rising number of cancer cases and the actual length of time that it takes to get to treatment? And I take absolutely, because I've heard it from many constituents, your point, Mark, that once you get into the system works well for you. But it's this getting into the system, and the elective care framework is not doing that. Cancer Research UK are calling for a specific cancer plan that deals with this emergency situation that we're experiencing. So is the elective care framework failing those cancer patients, and should we have a specific plan?
I'll start off first by saying I don't think, with the greatest respect to all, that we need any more plans or strategies. We need to change the culture of the way we deliver health and social care in this country. We have known for quite some time. And no matter what we say today, Diane, I think all of us have family members on those cancer pathways that are waiting far too long. A day is too long. And actually the number of individuals who have the fear of cancer but don't actually have cancer. And a lot of the strategies at the minute and a lot of the focus at the minute is actually trying to triage to get that individual, the lady with the breast lump, who until is shown and reassured that that's normal, will assume the worst. We all are humans in this room. I think it's back to the collective strategy of the sooner we know funding, the sooner we look at all avenues around capacity raising. And then I'm going to bring Lisa and Joanne in.
So just to say, through the work that we're doing in the elective care framework, through the work we're doing on the cancer strategy, there's targeted areas of focus, and we're very, because of our engagement with clinicians, because of the work that we're doing through the cancer strategy, we know where those areas of focus are. And Diane, you mentioned the breast, and there's a particular focus piece of work on breast in terms of driving down those waiting times for the initial breast assessment clinics. There are cancer reference groups that are looking at how cancer pathways can be streamlined.
Can I just, sorry to interrupt you, but we're getting worse. We're not getting better. We're actually getting worse. So I mean, in the previous quarter statistics, it was 6.8% were seen within 14 days. Now it's just over 5%. So we're actually failing more women. We're getting worse, despite all the grand plans. It's why I think we need to sort of separate it out and really focus our attention on this, because this is a terrible issue that we're being faced with. 29 new cancer cases every single day in Northern Ireland. But we're actually getting worse. Despite all of that, Joanne, we're not actually making improvements.
And I mean, there have been considerable improvements on the breast, from, albeit not a strong starting point, but there was work was done to regionalise the list, so that was to remove the inequality in provision across the province, and that has addressed
We've made
the
every
inequity in
area equally bad.
We have
we not? I mean, I'm not being contrary about this, but I feel very, very strongly that this is something that we should be this should be the highest level of our focus, and it isn't. And despite all and I'm not saying this, there's no one that wants to see this situation. I'm not. This is not an issue, between us. But I really do. I do think that there are issues that we really need to deal with.
And if I might just come in on the 14 days, because the Elective Care Framework does have, as part of the recurrent investment out of the 85, 5 million for recurrent investment to what should be a stronger, more responsive model. So we do have a breast operational delivery network that is learning from our Scottish colleagues and from those trusts that had shorter waiting times at a point in time, to actually see what is our optimum service model. And that's important, because you're absolutely right, the waits, we have too many waiting too long for breast. It is better than it was at its worst, but it's still not where you'd want it to be. But what we're seeing is, after triage, so from GP or from ED or anywhere, we are listing 1,563 women onto a breast red flag pathway every month. So that number has gone up, and we actually only have slots that can at this point in time do 1,293. So every month we are short 300, which is explaining. Now we have before Easter we were down to just over 5 weeks. With Easter we've gone up to 6.2 weeks for the longest wait or the average wait. But actually, the operational delivery model has to work out how do we deliver the 1563 plus whatever demand increase is going to be. And actually, that is so we are using the 5 million non-recurrently to do the additionality. And the reason we've had to use, and we're very grateful for our Scottish colleagues, is a lot of that workforce is a female workforce that has childcare commitments and and young families that don't want to do a lot of additional. And actually our model is to have enough core capacity to minimise additionality. So we have to learn how we're going to, and that's using skills mix. It's our linear pathway. Is it still the right thing? It's the breast pain going to different. So. Yeah. There is we do a 2-weekly report on breast. It goes up every 2 weeks to minister. So, and my team and myself, we present that and we go through all the numbers and all our actions. So there's a very high focus, because it's not acceptable at the current level.
I just ask one last question.
Just to mention that what also wasn't acceptable was postcode lottery. So some ladies were waiting up to 14 weeks, and you'll be familiar with that in your constituency, and that's not appropriate, that you have some meet a target and others don't. So the second issue, which is we have some really benign complex conditions that are really challenging as well. And whilst we all really know that it's so important for cancer, really important for cancer, we have some cancers where we haven't really changed the prognosis in the UK and Ireland in 40 years. We've got to really focus in on them. We're seeing, as CR UK said today, there's been an increased prognostic benefit, which is great, and that's a multidisciplinary approach. So whatever way you deal with this, of course, we want all people in Northern Ireland getting the timely access. And one example that Lisa said is in one mega clinic, 600 people were seen with routine breast referrals, i.e. the doctor was not worried that there's something sinister. Only 2 of those individuals had anything that might have been sinister. But 598 people got reassured on that day and came off the waiting list. Those are the strategies that we need to employ, and we're grateful to our colleagues to help us with that.
Can I just ask one last thing? So the waiting list reimbursement scheme, gosh, it's that long ago now, I've forgotten how much money was allocated to it. So if you can tell us how much was allocated to it and how much has been spent and what are the reasons for the spend?
Sure. So waiting list reimbursement, when we did the initial profiling of the 50 million, there was an indicative 10 million. Sorry, I'm looking to Joanne just to make sure I got it correct. 10 million out of the 50 million for the waiting list reimbursement. Mark has alluded to ROI prices have gone up, so actually it's more expensive. So we were getting less than we would have when we had a previous ROI scheme. So first tranche in that was to actually expand to Europe for the waiting list reimbursement. But actually it became clear the demand wasn't at the level of a previous scheme because probably the price differential. So what we have, so we agreed with Minister to profile that back and release money to the targeted procedures. So the 50 million has still been fully spent, but we have changed that initial profile.
Why does that 10 million?
4.49 million is currently committed as at February because we are not at year end. And that is 490 patients who have been approved with an average unit cost of £9,000 for treatment. That's what we're reimbursing, and 80% of all of those applications are, unsurprisingly, orthopaedics.
I would have imagined
so that's the breakdown. And so 4.49, so it'll go up. It might go up as much as up to 5 million for the full year. But we have not spent the other 5 million that I've already committed it elsewhere, so that we have fully committed the 50 million fully spent.
And that was an early decision. Diane, Minister has us meet him every 2 weeks, and when it was clear that all the money was not going to be spent in waiting list reimbursement scheme, the decision was taken very early that we need all the money we can get, and that came into the system again, and that has been reprofiled and used for cases here in Northern Ireland. Okay, and the 9,000 that you pay per patient, that's just like an average cost?
It's the average cost, and it's because we reimburse the NHS equivalent. So you may pay,
but you don't know what the actual charge would have been for patients.
We only confirm the amount that the
additional is up to the patient to pay. Okay, thank you.
I think it's fair to say that, look, this is a strategy that is still important because X number of people had a knee replacement, a hip replacement, a gallbladder or a hernia. But the difficulty is we talk about our health inequalities, and you have to pay up front, and if you're only getting tariff back and there's a financial loss, you are suffering that loss. So already it's selective, and we need an approach that deals with no matter what your worth is. Again, back to the ethos of the NHS.
500 people will think it's a very useful scheme.
Absolutely, and it's going
should have been less.
But those are 500 people who could afford to do it.
I'm hoping Linda gets a couple of questions in before you have to go, Mark.
I'm going to start where you've just finished off. So this isn't for yourselves, but I'm making the point because I want it on the record. The reason that the numbers are down in terms of people going to the south of the reimbursement scheme has very little to do with the additional cost and more to do with the 2-year implementation time at the beginning, which I raised here with officials, and they reduced to 1 year. I told them that it should be no years because the majority of people doing that are of 2 cohorts. They're, number one, people who are working in physical jobs need it done quickly so they can get back to their work, so they're in a position to pay for it. They just can't afford to pay for it. They can afford to pay if they get reimbursed some of it. And older people who know I'm not going to ever see this surgery and I'm going to use my pension. So that's the truth of it. I just think that
that's
needs to
really
be on the record. That's not unused.
I think that's a really important
That's
point,
a departmental.
Linda, and again, it's back to we need all the help we can get.
Not for yourselves, to be fair, but and I just wanted it on the record. Couple of quick questions just before you go. So the three that I want to focus on are the breast cancer, gynae and endometriosis, and you've already addressed a significant amount around the breast cancer, and like Diane and others, I've serious concerns around that. But the Minister has talked about the need to address inequalities, and this is a part of the big plan. I'm just wondering if we can identify anywhere in our health system where the waiting lists for diagnosis and treatment for issues as debilitating as the gynae and endo issues are for women across our health system is the case for men. And I know I might be going the other direction, but I don't think that there is anything that is comparable. And even when we talk about, and Nuala may speak to this, so I don't want you to even get into it in case she kills me, but the robotics, I mean, that has been in Belfast, and it's been used more or less almost exclusively for prostate, which is great, but it's not been used for endo, which it could actually make a real difference in. Now maybe that's because we don't have the specialists, and if we don't, then what are we doing to address that?
I'll take the robot because it's something close to my heart, Linda. So the really good news for committee is the robot is not now just for urology. The robot in Belfast is now being used by gynecology, upper GI, colorectal, urology, all using that to the point that the second robot has just arrived in Belfast. In terms of the West has just acquired a robot, and the South Eastern Trust have acquired a robot, and Lisa is putting together a task force that is going to look at ensuring that all the people of Northern Ireland and all the clinicians get the necessary robotic training. Number two is endometriosis is really important, and actually Lisa will come in on the operational delivery of 2 centres of excellence, because as you have said yourself, and we all know, and I'm even involved as a liver surgeon at times with ladies with endometriosis, it's a dreadfully complex condition. It affects the entire abdomen and elsewhere, and you need the combination of gynecologists, colorectal surgeons, even upper GI surgeons, multidisciplinary teams, and there's a massive amount of work for those ladies with really complex endometriosis. But I'm going to hand over to Lisa and Joanne just about the operational delivery of that.
Before you come in, is this specifically around the excision surgeries? Because I know lots of women who've had lots of surgeries and they haven't made a significant difference, maybe temporary relief, but is this specifically excision surgery?
And again, this is a really difficult condition because it keeps coming back, and even in the work that I was doing, which was taking the disease off the diaphragm, it's a long way from the uterus, but it was causing problems in the diaphragm. The nature of endometriosis is a horrendous condition, and you know, we have amazing clinicians who want and are driving the service to deliver to those individuals. And it's back to my comment to Diane around cancer is really important, don't get me wrong, it's life limiting, but there are other really complex benign conditions that are life limiting for lots of different reasons.
And I suppose, Linda, I was going to be a bit more specific about, I suppose, gynae mesh and endometriosis, if that's okay. You may be aware that we've had a gynae provider collaborative focusing on working together as one system, and they were deliberately, when they were working on targeted actions as part of ECF funding, they were working on anyone waiting for gynae procedures or outpatients that were waiting more than 3 years. So 3 years is still a long time, but we can see that those waiting for outpatient more than 3 years has reduced by 52%, and those waiting for inpatient or day case waiting to gynae procedures was reduced by 58%. And then with the mesh service specifically that's delivered with the Belfast, so the regional gynae removal of mesh, we are now at a position where the outpatient waits for any new assessments for that cohort is below the ministerial target of 9 weeks, and all patients awaiting review appointments are seen within their planned months, so that is progress for that smaller cohort. And then with regards to endometriosis, we have trusts currently working through business cases for the local expansion in the areas that are not going to be the 2 specialist hubs, as Mark has said. In parallel with that, 2 pieces, we've had an endometriosis clinical task and finish group which has now concluded its work, which has defined those clinical pathways for what could be managed in primary care, what can be managed in secondary care, so our DGH, district general hospitals, and what requires regional and tertiary intervention. So you'll not be surprised, the tertiary will be that involvement of the other specialties, the colorectal, the HPB, the urology clinicians. But those pathways cover assessment, investigation, test, medication, self-management, and also have the referral thresholds, and we do it once and we standardise it. So the business cases for the regional tertiary centres, which are going to be Belfast and West, we expect those business cases to be submitted into SPBG in the next couple of weeks. We are having to take a phased approach because with the gynae allocation that we have within the 85 million, the 3 million, and then we would expect to use some of the 80 million to actually ensure that we can actually deliver those pathways and those sites. So that is our expectation. But there has been a really good multidisciplinary approach, because it's not just, with respect, Mark, it's not all about surgeons, because it's the nurses, the physios, the psychology wraparound services, the chronic pain management, because actually some of this will be chronic pain. And we don't want a dependency on addictive drugs, so that we've had to take a very multidisciplinary approach, and the clinical task and finish group has delivered an excellent piece of work.
Just before Linda, you come in, I'm going to have to allow
Chair, I'm so sorry, committee, my apologies.
We appreciate you giving us your time, and we don't want to hold you back from your other engagements.
I'm leaving you in capable hands.
Absolutely.
I can assure you.
Your fly getting away before I get stuck in.
As Lisa said, it's not all about surgeons. Sorry, Linda, go ahead.
No, it's okay. Lisa, I'm probably going to come back to you on the endo stuff, right? Because I think that there is a significant conversation to be had around that. Is there anything that you can think of, Mark got away before you had answered that one, that you can think of that is comparable in terms of men, the length of diagnosis? We know it's 9 years. It's 9 years minimum. Almost at this stage, that's not even the maximum, that's almost the minimum at this point for women to be diagnosed, never mind anything else with endometriosis. But in terms of the gynae waiting lists and the endo, can you think of anything that is comparable in terms of male-only health conditions?
I'd need to look, because we can certainly profile, I would have a profile of all specialties, but not at subspecialty level, because sometimes it's the subspecialty, because I think endometriosis is almost hidden in that. So we certainly would have a profile of specialty level waiting times for assessment and then the waiting times for treatments. But I wouldn't have it at subspecialty, but we can certainly have a look. Orthopedics, some of the spine, they have very long outpatients and very long treatment waits, but then that's not gender specific. I get your point, absolutely get your point.
So
yeah,
I think the answer is no. Just anecdotally, as somebody who represents constituents right across, I can't think of any issue that men have come to me on this scale, that women are coming around not being able to access diagnosis, not being able to access treatment, and when they're getting treatment, the treatment is not suitable, is not right, is not, the expertise is not there. I just don't think it exists. I just think that it needs to be said, and we need to be straight about it. So
could just, I suppose, from a policy perspective, and I'm sure you're aware that work is underway in relation to developing a women's health action plan, and there's been a huge listening exercise with stakeholders. It's been led by Queen's and Derry. Well, women are taking forward that bit of work, and I know that endometriosis is coming through as part of that engagement process and will feature in this Women's Health Action Plan. So it's just that it's there, it's being listened to, it's on the radar, and then supplemented by the detailed work that Lisa's alluded to that's happening out in the system.
I understand this. This is not a criticism of yourselves. This is historical. This is something that we have an awful lot of catching up to do, which is why I want to keep it on the agenda. It needs to be prioritised because women are being failed day and daily. My last question, and it might be something that you might want to come back to us on. So it's just this issue around the movement in terms of the lists, you know, and not knowing whether people have, and it was one of the questions I was going to ask, is, you know, if people have passed away, can they potentially, we have the answer that they are actually still on the lists. I'm concerned about that because they're still on the list. That also is an area of concern because families then are getting appointments for somebody who's passed on, and that's an appointment in relation to why they died. That's going to be really traumatic for some families, or if they're waiting on a test for heart exam.
And some of that is, you know, we've pulled a report, and at a point in time we've been able to, it's not necessarily that a patient or a family has been contacted to indicate the patient is deceased, because we do pull the death notification information into our health systems, and that there is a small window between that update. Now, I couldn't say that a patient hasn't died, the family hasn't been contacted, but that vast majority is because we've been notified through other health systems that actually that individual, so therefore I suppose we were being open. We removed patients from waiting lists for other reasons other than validation or treatment. They may have passed away since they were added. So that's what we were talking about deceased patients.
So I suppose what I want to say, and the reason I'm saying you might want to come back to us in this, is a plan for how we're going to actually identify that movement, where it's going, who it is, you know, who has been seen, who doesn't, as Solicitor Taylor outlined, who doesn't any longer require the treatment. And so it's a plan, and whether that's used in Encompass or what.
It'll be an Encompass build, and it's replicating what we previously would have through I managed cancer services for a long time ago. So it's that cancer tracking system. So it's replicating some of those reports, and they are on the list for build. But there are other reports that are being built in parallel. So that's what it will be. But we're happy to pick it up with our DHC&I colleagues.
And this is one that I wish Mark was still here for, because I don't know if you're going to be able to answer it. But the endoscopy, which was outlined by Diane, I'm particularly thinking of the colonoscopy end of it. And I mean, we have had some presentations previously, not at committee, but at different events that we've been at, around that is quite an invasive procedure, certainly not pleasant for anybody to have, and the potential for the FIT test to deal with some of that. And I'm not really sure why I've never really understood fully when I've asked this question why we're not making more use of that rather than the colonoscopy.
That's probably clinical.
And I'm happy if he's want to come back to me.
No, that's okay.
That's 100%. I have no problem with that. But if we can get something back on that in writing, because I know it's not straightforward. The issue that Diane raised, even when you have that endoscopy and the pathways, is that you may well be sent for a colonoscopy, and that then may be a closed case, but you may be having another test that will identify that you have cancer somewhere else. It's a multitude of things. Yeah. So this is complex. It's not. We won't necessarily be able to get this information because of that reason. So I understand all of that, but if we can just get an answer to that, why we're not.
And because we certainly have the outpatient weights, and then the reason we don't take our outpatient weights and our diagnostic weights and our treatment weights and just add them together referral to treatment is because lots of things happen in parallel. But for example, when a scope has a confirmation of further investigations, that is recorded. They are planned appointments with that team, and at a point in time, you then move to treatment, and you're captured in that treatment list. But there is an overlap between outpatients and diagnostics, and actually in some cases we use diagnostics before you get anywhere near an outpatient, because a straight to test may be the appropriate thing. A long time ago we moved from doing what was a prostate biopsy to actually making sure you did an MRI first, because why would you do an invasive when the evidence would say the MRI is better? And actually sometimes patients go straight to that before they come to an outpatient to then have a conversation about a biopsy. So it is important, and that's, that's where I think we need that Encompass build to actually give you the answers that you're looking for, which captures closed episodes at diagnostic who may have been on a red flag pathway, closed episodes at an urgent, and actually very small numbers, but anybody else that we're actually then diverting onto a pathway because there's an incidental finding and nobody expected this to go that way. All of those reports are really important because they help us better design our clinic templates, help us better do our scheduling, and now the service managements and teams will have a lot of that information, but being able to extract it and give it to you in a format that our statisticians are able to stand over and meet their requirements is probably where we are at the moment. But there's a lot of management information. My team use management information every day, as do the trusts, but we are restricted as to what level of that we can actually put into the public domain, because it wouldn't meet official statistics standards that our NISRA and IAD colleagues have to stand over. But we can certainly get an update on the Encompass builds, because that's what our official statistics will then pull from and then make that a formal public document.
Okay,
If
thanks.
content.
Noah?
Hello, thank you for the presentation and answering the questions so far. I have gone back to a couple of the other questions that people asked, and I'll just kind of work backwards. And regarding just Linda's question on the Da Vinci robot, I hope in the Belfast Trust that it is being targeted, the new one, towards gynae, rather than, more targeted and weighted towards the others, because there was quite an overwhelming gender imbalance in terms of how it was applied, because it was just for urology and obvious reasons there why it would be. However, it would be good if that could be then utilised in the future for waiting lists for surgeries. I do want to ask then a question around the breast cancer window that Diane brought up too. Before that was that, is there any long-term planning in terms of how we might see this sustainable into the future? Because I know we're kind of trying to get the weight down at the minute, but we saw, a decrease. It got better and then it slightly got worse again.
Yeah.
What does that say for long-term planning of the 14-day target?
The long-term plan is the work of the operational delivery network to design that the optimal service model, and that's where we'll be putting the 5 million recurrent investment. So that will be ensuring we have the right number and right skills mix. So that is the long term, because otherwise we are, Easter was a holiday, so there was less additional clinics done during Easter. That's not the long-term model. We shouldn't be delivering a service that's so dependent on additionality. So therefore the operational delivery network's optimal service model will give us the workforce and the pathways, and it's really learning from those other high performing
Do you think you'd be able to then, in that optimal service model, so then are you planning then to recruit into the additional workforce? And if that you said, because it's that 5 million, what are the plans for when that's actually going to happen then, so that we can kind of see, long term into the future when this might permanently get better?
So the expectation is that model will be defined in this financial year, with spend being incurred. At least because there is a lead in time for recruitment, you would expect, or you would hope, that there would be some Q4 recurrent, in terms of people having been recruited. But we are using that money to ensure that we are doing that additionality, which is on the short term, because what we don't want is the 6 weeks to go all the way back out again. But that there is some expectation that actually, this additionality at the numbers that we're doing is not a long-term or even a medium solution. We need to make progress. And we do have all the right people in the room to talk about it.
Do you think that you could maybe come back to the committee, keep us updated, just, as to when that has been implemented in terms of the additional workforce? We will obviously ask as well, but it would be nice if it was a kind of a proactive, great news, this is what we've got, so that we don't have to always go back. And then again, just go back to the 80 million that's been discussed out of the over 200. And I know you talked about the 73.5 back to the centre as it was non-ring fenced. When I think back to what the original kind of sums were about, and I know that there was only 50 million that was additional, in the kind of programme for government and in the executive, there was an agreement for additional appointments. So what was that baselined against? So what was additional, and what is additional, and what have been the last previous year's baseline? Because I know you said you wanted to deliver 70,000 and we've delivered more, but of that 70,000, say it was a nice number that fit, how much of it was additional than what is the previous baseline?
So the programme for government with the 85 and therefore the 50 and the 50 million, because they were the targeted for the delivery of the 70,000, and then the 80 million was core capacity. So the 70,000 was just a confirmation of additional 70,000 patients that would previously not have been treated. Now we were using, the previous year we used 75 million for additional new review outpatients, diagnostics, treatments and AHPs for cancer and time critical. So there was 75 million and that would have been in the region of 100 and it might have been 197,000 additional. So I'm not sure where the 70,000 calculation came, because it was given, that's what was articulated to health as the 70,000, but we have more than delivered a 70,000 of additionality. So there's the 237 already through the 85 plus the backlog activity plus primary care elective plus the waiting list. So we have, even without using the 73.5, but actually we wouldn't have stopped at 70,000. It would have been entirely inappropriate to stop it, having only just delivered 70,000.
Okay, so the whole 237, they aren't additional. They are what?
No, they are. That's
they
additional.
Are additional.
That's entire. 237,000 are additional pay. We have receipts and invoices that correlate to the activity for all of those patients. So that's that is true additionality, as is the backlog activity and the primary care elective and the waiting list reimbursements. They are patients.
So what would the full total be?
Full total when I had those. Oh, sorry. As the economist, you'd have thought that I would have added all those numbers up. I haven't, sorry. Now, I can tell you total spend has been 141.5 because I did do that calculation. Oh, my apologies, Nearly, you've caught me on the hoof completely. 16.
So if it was the same as the previous financial year, how many would you have seen?
The previous financial year, we used baseline funds to do 75 million for red flag and time critical. So we have exceeded, on a pro rata what that would have been. And then we wouldn't have had the backlog additionality, so that even looking at that, we wouldn't have had the 28,000 last year.
But you don't know how much that 75 million for the year previous is in terms of people?
Apologies, it's probably in this. I'll have to come back. I suspect it's in this entire pack. Sorry.
It's just like it's you can't really. I know it's important to look at resources and the amount spent, but money and people aren't a direct comparison. So it's just to see, what type of improvement are we looking at here, and is this actually sustainable into the long term? Well, we know if it's additional resources that we can't do it every year, but it's if we then calculate for over a 5-10 year plan, at what point is this going to come back again? At what point will we back to 4-year rates, 3-year rates? Yeah. So it's important. The reason why I ask for that is so we can, in our heads, when we're scrutinise the figures, say, okay, that's fixing it for the next 2-3 years, but actually in 3 years, we're going to be right back where we started. What's the long-term planning? So it's just for context for why we're kind of wanting those numbers.
Yeah, I think it's it's important to note that that's why the capacity building is so important. So the capacity building is... So it's a multi-strand approach. So yes, we have the investment through the waiting list initiatives and these additional procedures because our waiting lists are so significant. And without that capacity building, yes, we would continue to be in the same situation. But if we can build our own core capacity, that's how we make that move towards managing the demand capacity gap. And through building our core capacity, we should see the reliance on that additional funding then coming down.
Where are you getting the core capacity? So not in terms of the funding, but the actual physicality of it. Like where are you getting it from? Where are these people are?
So that's either additional training programs that we're then earmarking for additional consultants at the end, or it's the recruitment exercises that we're doing, and it's the skills mix for those recruitments. So going out and making sure we have a multidisciplinary. So capacity building takes time because and sometimes it also requires additional decontamination equipment. Capital refurb is required for capacity building, but they are nearly, recruitment and trying to attract and trying to retain.
So in terms of recruitment and trying to recruit and attract, but more places, more training places, the training places will be the longest. That'll just quite matter of fact be the longest. Trying to attract. So are we talking then here about an increase in salaries, and how are we going to make this attractive when we're looking at the Republic in order and what they're attracting from here in order to actually sustain this in the long term?
And we're not looking to match the ROI salaries. That wouldn't be a model that we would be following.
Oh no,
through.
I completely understand why it's
but in terms of, so often retention and recruitment can be really difficult if a service is seen to have quite an unattractive on-call rota because you've got too many vacancies. So each time you signal additional training places or you go out for a number of vacancy posts to be filled, you're more likely to attract, and you're also likely to stop the people who don't want to be on a 1 in 4 rota but would be happy being on a 1 in 7. They're more likely to stay. So we look at retention and recruitment as the same thing: hold our workforce but also attract. So that's what we're doing with training numbers. That's what we're doing with, and we have a couple of examples in specialties where actually we think we should be going out to the rest of the UK to say Northern Ireland wants to recruit a substantial cohort of surgeons in this specialty, and actually we do one exercise, they work together as a network. But it's an important signal because often people will look to see, can I have a different on-call rota? Can I be paid more elsewhere? So actually recruitment and retention has to be done hand in hand, but it's not at the expense of blank cheques, because that's not value for money.
As Lisa had said earlier, looking at the skills mix is also quite an important factor. So moving away from sort of traditional led models and bringing in some more advanced practice and giving other professionals part of that multidisciplinary team. So it's looking at different ways of working, different skills mix, building different teams, and that then can be attractive for the likes of career progression and giving members of staff the opportunity to develop new skills and develop new training and advanced practice in particular areas, which will overall help then the service delivery model as well.
No, I understand. I think that, obviously that is very important, the multidisciplinary levels, but there will be a reality that there is a lot of consultant-led posts that will need to be recruited for. Has this been successful anywhere else in terms of health services that that have been shrinking in terms of their workforce, competing with other markets? Have you actually looked as if whether they've been successful in attracting people back into it?
And I suppose when we look at England, you're looking at competing between regions and much more of a population of workforce. So even England, Scotland and Wales. But actually the reason we have the NHS Scotland team helping us with breast is because they were experiencing the same level of challenge across, what is a smaller population. And that's where the skills mix is going to be really important. So we are learning where it's appropriate, but it's not always easy to find a comparator in terms of recruitment and retention for a cohort serving a population of 1.9 and then your subspecialties below that. But we do look to see how others have attracted individuals. And to be honest, the robot is one of our, the availability of robot is one way of ensuring that our trainees do not go elsewhere, and often they won't come back. So, the robotic development is really important, and it's probably more a retention, because it takes quite a lot of volumes to get through, and yes, there are some consumable savings, but you do have to do a substantial volume to see a length of stay change. So we haven't invested in robots on an efficiency and productivity. We are absolutely clear that they are safe, but actually it's about keeping our workforce and attracting the best of the best to us to work in our services. So robot is one of the examples, and we learnt that from the amount of robots that were appearing in England, Scotland and Wales. It was critical for foundation
all the
training.
trainees wanted to go there because they all want to
Yeah.
do where it's most popular and where it's the newest style of medicine, and that's why the consultants here were fighting for it and over it. At times, I do recognise it's hard. It's very hard to kind of get our waiting lists on a more acceptable and sustainable basis. But I do have concerns about that long term being able to reach it in terms of sustainability. My final question is around theatre utilisation in target and waiting lists. And I was looking at it, and I've asked this question a number of times at various health committees around maximisation, utilisation of theatres. And there is a concern that perhaps are we talking about theatre utilisation in terms of number of patients, or the fact that there are simply patients who will have to wait in theatre spaces before they can move into the likes of ICU. And that theatre then, on the face of it, is seen as being used. But actually you've got a patient who's been in that theatre post-op recovery for quite a few hours. So it's not optimization, it's being used. So have we actually done a piece on that, on whether we are using it and optimizing the number?
Really, we have very robust data on theatre utilisation. So theatre utilisation is operating time and run time. And that Mark has alluded to, late starts, early finishes. So we have a lot of information that's actually true treatment in theatres. We would not include time spent whilst waiting for an ICU bed as theatre utilisation, because we work on the run time and operating time. So and we use the same methodology as NHS England, Scotland and Wales. And we have, we also look at utilisation of commission sessions, so our trust using the appropriate number of sessions that we've paid for. So we have all that information as well, but we certainly look at operating time and we look at run time because one of them takes account of the anaesthetic
and
prep.
Are they trusts using the utilisation of commission
we are
sessions?
sitting at is it 86%? It's 85 or 86%, depending if it's January or February, against a target of 90. So we still have a little bit of work to do, but it is better than it has been. So theatre utilisation is sitting. Now we do have, that's all theatres. So then we have information on commission sessions being used. So, and if I focus on those sites that are in our elective care framework, so the OMA Day Procedure Centre uses 98% of their commission sessions, and Lagan Valley is sitting at 87 with the trajectory, and then we have the SWA has used 100% of their commissioned sessions. So we keep a very close eye. The theatre time and our surgeon time is our most expensive resource, so we have to make sure we fully utilise it. And
how many are we talking about? Maybe not for now, but in terms of 98%, it's a fantastic figure, and so was 100. But it's, are we talking about hundreds of patients and not just 10 or 20 or?
Well, our day procedure centres, so Lagan Valley and OMA, Since they're operational, they have treated 23,283 patients plus 19,000. That's in their day procedure. So their day procedure centres. So yes, theatres and some of them may be outpatients with procedures in that setting, but it's the day casework. But they've also done 19,000 scopes in those sites, so that's a substantial volume. And then our elective overnight stay centres, so they're the slightly more complex. So the Daisy Hill, Matter and SWA have seen 24,962 patients going through those. So they are patients who maybe would have waited for a main theatre in a different site and would have been competing with ICU and or HDU. Alongside those investments for the elective overnight stay centres, we've had the post-anaesthetic care unit beds, the PACU, which is the, you need some monitoring, but you don't need an ICU bed, you don't need a HDU, because that's a way of getting more elective patients through, because you're not competing for the highest level of ICU beds with unscheduled care patients. So we have quite a robust theatre productivity programme that's looking at all of this, and we have. Through our support and intervention framework, we have various escalated actions with various sites to actually improve productivity and efficiency across elective as well.
And do you think this success of 98%, 87%, 100 in targeting these as either day procedure hubs, elective overnight hubs, really speaks to what could be the success of the entire transformation of the health service, that actually some sites are better utilised as this, and not every service can nor should run in every hospital, but also does it speak to the possibility of the protection of some sites, such as the Belfast Royal, for protected categories or specialties that can only be performed in those ones? Do you see this as a evidence building that this needs to happen and this change needs to be permanent?
Yeah, and it's certainly the premise of the elective care framework. I sat on the original task and finish group that actually looked at what does elective care centres look like, how do we better protect elective, and even the conversations we're having and the planning that we're doing at the moment is we ideally would like to use the 80 million to ensure that we can put as much elective activity through Daisy Hill, through SWA, through the Causeway site, to actually make sure that we can get more and more activity, because there are uncommissioned theatres that actually we want to buy and buy the workforce too, and that's exactly in keeping with the elective care framework and the previous task and finish group.
Okay, I need to move on.
Thank you.
Thanks, Nola. Alan Robinson.
Thanks, Chair. I'm conscious that we're almost 2 hours into this now, so I'll be as quick as I possibly can. The RCEM were able to publish their report just last week, which they were able to detail the large numbers who have died due to long waits in EDs. The validation piece within your paper there, you refer to the patient cannot be contacted. Does that include those who have died? And can you pull down, you talked, Lisa, about being able to draw down numbers in terms of deaths. Have you figures, or what are the annual figures of those who have died waiting, particularly those in the long waits?
Who died on a waiting list? At the totality of information, I suppose we have information that shows removals from a waiting list due to death, so we would have that information. But as I said earlier, it doesn't mean that we've contacted them. It just means that was their reason for removal from a waiting list.
What are those figures?
So sorry, I didn't have movement. Bear with me, sorry. So for outpatient waits, and this is a report which covers last year, 5,994 patients had a code that said they were removed from an outpatient waiting list because they were deceased.
And that's over a 1 year period?
Yes, that year.
And how far back are they collated?
I would imagine we have legacy information as well, as this will have been coming from the Encompass system. So I would imagine it's in the legacy systems, but I don't remember seeing previous reports on that. But I can have a look.
I mean, it is natural that people will die on a
waiting
list.
Yeah.
But is there information broken down as to, those who have died as a result
No,
Oh,
we wouldn't have that
No,
level of
no, okay.
information, no.
Fair enough, okay. Just the other question, and Nuala and others were touching upon it, the last informal session that we had, I think, Joanne, you were at it, and Mark was at it, and he talked about a number of hospitals that were performing very, very well in terms of elective care, and he touched upon a couple of them that he thought that could be doing more, and that had the capacity to do more. He talked about Causeway Hospital could do more. Are we any closer to seeing Causeway being ramped up to the capacity that we all know that it can deliver?
And certainly they are, as I've alluded to, that is the work that we've been doing, because Causeway is a site that could be doing a lot of the northwest elective work and do it with Western Trust colleagues as well, and actually use resource once, either by taking patients or having an in-reach. So we've been looking at Causeway, but we do require that, in able to fund that, it is part of the expansion, the 80 million. So Causeway's in that space, Daisy Hill's absolutely in that space, SWA's in that space, to actually say, we need to maximise what we have, and how do we do that? So there are plans and comments. So the Southern Trust is putting forward their proposals for Daisy Hill, the Western Trust for SWA. I'm working with the Northern Trust and the Western Trust to look at the options for Causeway.
One of the keys is ring fencing that 80 million that Mark
There is an element of general surgery that was part of the red flag and time critical, because that would be the the cancer general surgery. So some of Mark's work would fall into that. But actually, to do everything that we would want to do, and general surgery and gynae and ENT are those sorts of procedures that we would be wanting to do. An element of it does have to come from the 80 million for an expansion.
Okay, thank you.
Thanks, Chair. Certainly over recent days, members of my family have been called in over the weekend for diagnostic tests, and have come away with good news, which lifts a weight off people's shoulders. So I can see that the drive to bring down waiting lists is for real. It is happening. I'd be disappointed if the morale of the staff who are working overtime and working at weekends was in any way impacted by any external cynicism over the improving activity figures that we're hearing. We all realise lots of work still to be done to get where we need to be. But I would also, I think we need to be careful as well that we don't give staff the impression that there's damn to the do and damn to the don't, because they are definitely making the effort, and I certainly want to record my appreciation to them for their efforts to date. But there is a worrying bit of news coming down the track, and that is, in recent days, is the potential of a doctor strike, with the BMA proposing to ballot their members regarding strike action. What would you anticipate would be the impact on all the good work that you've been doing to date and the improved figures on waiting lists? What would be the anticipated impact on all that work? Is it liable to be, lots of it liable to be undone? Now, we don't know what length or what way the doctor strike would work out, but any delay or any impact of doctor strike is I'm sure would have some sort of a negative impact. But what would be your assessment?
So the previous single, when you look at the monitoring of single day previous junior strike, it did have an impact on acute elective delivery. So the monitoring information would show that a single day, we saw some 4,049 outpatients cancelled or not scheduled, and 270 treatments. So that's the junior doctor component of that, and that's elective because we manage the unscheduled with the junior doctor absence with senior decision makers. So that's from our previous strike, and it would probably be in the region of that, I would expect, depending on the day of the week. But yes.
Yeah, let's hope it doesn't happen. Thank you. Thank you, Chair.
Okay, thank you. So that was 2 hours, and the reason why I allowed it to go for 2 hours is not only is it an executive priority, I think it's a priority of every citizen here in the north, and it's important that we give it the time to allow everybody to ask the important questions and allow you to give us the answers, which hopefully will reassure people that that good work is being done. So I thank you very much for allowing us to keep you for so long.
Thank you.
Okay, members. Sorry, the only thing is I should just reiterate before you go, there was a number of things that you've committed to coming back to us on, so we'll hopefully see that in the near future. Moving backwards then, members, to the agenda. So, Chair's business. Yes.
Can I just
Yes, go ahead.
follow up on the committee? So one of the things that is stark about presentations like this, particularly when you look at the issues around validation of waiting lists. I mean, I had actually, it had been asked, so I didn't ask it, that over 46% of those people who are counted as a reduction in the waiting list in the South Eastern Trust were actually taken off the list without being seen. So the validation process was that they were not seen. And they've all explained there are many reasons for that, etc., etc. I'm not challenging that at all. But it does give us a real fear for the actual data that is held by our health service. And if data is important in driving efficiency and directing resources, 46% of people who are on a waiting list over 5 years who are not seen is quite, I think it's massive. And perhaps that is something that the committee might want to ask more specifically as to, so that's the data for the 4 years plus. So how are they monitoring other data to make sure that it's much more up to date? Or maybe that's something that they can't give us, because they don't seem to have data which tells us once you've had a scope of whatever kind that actually tells us what way your treatment has progressed. They don't seem to have that data either. That data is available in England, for example.
Yeah. And I mean, I was going to ask the question about Encompass in future being able to provide us with more transparency around, particularly around the validation issue. So I'm not sure how we formulate a question in relation to that.
Schedule briefing with Encompass.
Oh well, that might well be
In the June, early July.
So the clerk's just saying that we have a briefing scheduled with Encompass in early June or July, so we might be able to ask them. I mean, that's not to say we can't go back and ask for that information, but it might be worth waiting until we deal with Encompass.
I think the one thing I would really like to see us having is so that we can't say, look, really well done, so many people have had scopes, etc., etc., but we don't know how many people actually then required treatment and how many people went on to a waiting list, or hopefully if it was red flag they were seen. But I think that referral to treatment pathway, which is in place in other parts of the United Kingdom, it's perhaps important to ask, is there any attempt to bring that in so that we understand the data that is being presented to us more coherently?
I mean, one other thing that struck me through everybody's questioning is, not to step on anybody's toes, namely the Minister or the Executive, but perhaps there needs to be a better metric of movement than the 70,000 additional.
Yeah, I entirely. I mean, Nuala asked the question about how was that baselined, and we didn't really get an answer to that. I suspect that's what the Department of Health thought they could deliver.
And it might be a better way.
And it's important to understand how we make those assumptions.
Targets are always very arbitrary, whether they're in health or any other thing. But you know, we still have long waiting lists. Perhaps a better target would be, you know, nobody waiting for 4 years. I don't know, but it's definitely something that we should, I think, give consideration to, if that 70,000 is the best metric for measuring progress on this issue. Linda, you looking at?
Just 2 quick points. The first one is the waiting list or the waiting list, but if it's 9 years till you're diagnosed and then you're going on a waiting list, there's potentially at least hundreds, but probably thousands of women out there that should be on a waiting list somewhere that aren't. So I think we just need to understand that. I understand what Deanna's saying. Maybe the thing we need to look at is how do they do it in those other places, so therefore why can it not be done here? So is there a way
fairly
of
standard
so
metric that they
but that's
employ.
that's
And
the point.
I'm sure it's
how do
not
they do it?
that.
And can we maybe see, is there a way, Keith, of asking the trusts what the limitations of Encompass are before we get the presentation for Encompass to tell us all the good things about it? And we're sitting here thinking that's wonderful. But we know from going to the Southern Trust that a number of significant limitations were highlighted around what can actually... Now, there were some good things, absolutely, but there were significant limitations in terms... There were good things in terms of how it would help, how it's helping them to do their job. But in terms of that data collection and what can be done with that information then going forward, they seem to be saying it's fairly limited, and that would be concerning because we thought this was going to be our great white hope.
Also, I think it would be really useful for the Encompass presentation is to get the up-to-date costs plus all of the running costs of Encompass. I think that might be quite revealing.
Indeed.
I've
Okay.
seen some
For the life of
figures.
us, so we might not want to say that.
So we moving backwards then, as I say, we'll pick up on those issues.
Right, Chair.
You're all right. So Chair's business. So we had the meeting with the Professional Standards Agency, and I'll come back to that in a later item on the CLAR. Just for information, I was at a vigil out here yesterday in relation to lobular cancer. So I just want to pay tribute to all the people who came to that vigil. I mean, there's a campaign to try and get funding for research and early diagnostics, which is vitally important given the conversation that we've just had, primarily from the Westminster government. So I just want to pay tribute to all those involved in that campaign. And then secondly, myself and Danny attended and spoke at the Mental Health Champions report launched today in the Long Gallery. So it's quite an extensive report analysing and bringing us up to date with the mental health picture across the north, and nobody will be surprised to hear me telling it's a pretty bleak picture. Things are, in some cases there's some improvements, but overall things are getting worse. So I mean, I would encourage everybody to read that report because it's an important piece of work. And just to thank the Mental Health Champion for inviting us to speak at the event and for putting on the event in this building today. Moving on then, draft minutes. Can I refer members to the draft minutes?
I don't know whether to raise this here or...
Any other business? Yeah.
That's fine.
Draft minutes, refer members to draft minutes of the meeting held on 16th of April, page 6. Everybody content? Matters arising? None. Okay, item number 5, which is the SR 2026/66, the Pharmaceutical Society regulation. So can I refer members to papers at page 18 of the main pack? Includes clerk memo at page 19. The proposed SR and EM are pages 23 and 26. So the committee considered this proposal for the statutory rule at its meetings on the 12th and 19th of March, during which we heard oral evidence from the Pharmaceutical Society, considered 4 public responses and reviewed a requested response from CPNI. At our meeting on the 19th of March, the committee agreed it was content that for the Pharmaceutical Society to make the statutory rule. As I've said just there a minute ago, met with the Professional Standards Authority on Tuesday in relation to their report on the Pharmaceutical Society, and we've received further information from the Pharmaceutical Society on online pharmacy. So the Pharmaceutical Society have confirmed that there have been no changes to the policy content since the SL1 was submitted to the committee. I'm going to ask now if members are content with the SR.
Sorry, can I come in on something there? Yeah, I noted that they have improved from 11 out of 18 to 14 out of 18 standards that are met. But I understand that some of these were basic improvements that should already have been made. Yes. And the ones that are outstanding, that still remain outstanding, do seem quite serious.
Yes.
And will require a lot more of work. And they seem to be patient safety issues as well, particularly the fitness to practice issue and the online pharmacy issue.
Yeah, go ahead.
Sorry. Is there any way we could get regular updates on the progress against them?
When I met with the professional standards, I mean, they're engaging regularly with the Pharmaceutical Society, so I mean they'll obviously be coming back to us with their yearly report, but I mean I don't see any issue if we can write to both organisations and ask for regular updates.
I think that would be good. I think, you know, they are concerning, these, and I think committee should be you know, have a view on how they are progressing.
Yep.
Thank you.
Chair, so this will last for how long?
It'll last
Just
until
one increase in fees and that's it? It's
until they bring forward something
another
else.
increase in fees?
If they do.
Well,
I mean, this is the first increase in a number of years, so.
yeah. I mean, I must say I'm with Danny in this. I read the outstanding actions that are still not addressed. They've addressed some, which seems to me the easier bits of it that are addressed, but not the more difficult one. Yet we are saying that there should be an increase in fees. And I understand that they're saying if we don't have an increase in fees, we don't have the staff and people to actually address them. But we should have some way of monitoring, because we're giving permission for an increase in fees. We should have some way of monitoring how that has worked.
Yeah. I mean, it's something that we can. I mean, we have to take a view on the SR, but we could also have a view on the frequency of the increase in fees if we want to suggest that.
Yeah, I mean,
Although
I'd just like to see a better performance from the organisation, and there is like significant resistance to the increase in fees. It's not huge, but it still is quite an increase, and I just think that without any method of monitoring performance, we're agreeing to something. I don't know, I think that's
okay. So, I mean, all we're being asked for today is a view on this SR, but we can, as I say, have our own thoughts on the progress. So, I mean, I'm happy that the committee write for more regular updates, and that we can have put some kind of addendum in relation to, you know, we certainly wouldn't be considering any increase in view on fees unless we see considerable improvements.
Yeah.
Are people content with that?
Yeah.
Okay, thank you. So I have to ask formally, that the Committee for Health has considered SR 2026/66, the Pharmaceutical Society of NA General Amendment Regulations NA 2026, and has no objections to the rule. Content.
Yes.
Okay, item number 6, SR 2026/72. So this is the Health and Personal Social Services GM Services Contracts Prescription of Drugs Amendment. Refer members to papers at page 84 of the main pack. There's a clerk's memo at page 85. The SR and EM are at pages 88 and 90. So we noted the proposal for this statutory rule on 26th of February, and we issued a call for views that same day, which closed on the 11th of March. We didn't receive any responses and no issues were identified. The committee considered the proposed rule on 26th of March and agreed that it was content with the policy merits and for the department to make the rule. The department has confirmed that there have been no changes to the policy content since the SL1 was submitted to the committee. So are members content with the SR? Okay, formally I'm going to have to ask, the Committee for Health has considered SR 2026/72, the Health and Personal Services, Social Services, GMSC, Prescription of Drugs Amendment Regulations, and has no objections to the rule. No. Okay. Item number 7, SR 2026/73, the Firefighters Pension Scheme, and this is Amendment Regulations NI 2026. It's at papers are at page 102 with a clerk's memo at 103, and then the proposed SR and EM are at pages 106 and 110. Committee noted the proposal for this statutory rule on the 12th of February, issued call for views on the same day, that closed on the 25th of February. No responses were received, no issues identified. We considered the proposed rule on the 5th of March and agreed that it was content, we were content with the policy merits for the department to make the statutory rule. Department has confirmed that there have been no changes to the policy content since the SL1 was submitted to the committee. So are we content? Okay, formally again, I'm going to ask if the Committee for Health has considered SR 2026/73, the Firefighters Pension Scheme 2026, and there's no objections there. Content. Thank you. Okay. Item number 9 is a written briefing from the Department on referral pathways within the Committee's strategic priority. So, members, there's a written briefing at page 244 of the main pack, just asking if anybody has any comments.
Not in it. It's the truth.
One thing, Chair.
Go ahead, Danny.
I know we had a briefing on the neighbourhood model recently, and I'm just concerned about some of the timescales that were related to us within that, about the development of the INTs in particular. I'm wondering if we could write and just ask for progress and a timescale on them come together.
Yep. Okay. And just from my own, page 248, saying the Western is the only trust with a dedicated care management budget for autistic adults without statutory eligibility, and I'm just wondering if we could maybe potentially write, why is there an absence of that equivalent provision in other trusts as well? Anybody any other remarks they want to make? No? Okay. Written briefing then, item number 10 from the Department, Invest to Save and Preventative Policy within the Transformation Agenda. So can I refer members to the written briefing at page 251 of the main pack and ask if members have any comments. So just, I mean, this is obviously, Invest to Save is important to us all. The Department is conducting comprehensive budget review to identify savings which could potentially just discontinue some funding areas next year. So, I mean, given the scale and potential impact of the budget review, I suppose I'd like to know if we could ask the Department to commit to keeping us as a committee informed, sort of on an ongoing basis, including clear reporting and decisions taken that might impact service. If people are content.
Yep.
Any other comments? No. Okay. Item number 11, correspondence. So, can I refer members to? Sorry, you look.
Chair, can I just maybe
go back?
Mention just on that Invest to Save again? Apart from given all of the talk that there is around women's health care, the need for a women's health strategy, the need for a women's health action plan, I really don't care what you call it. There's one thing on that references specifically women, and it's actually more to benefit their babies, which is the right thing, but it's breastfeeding, which is something I'm very, very passionate about. So I'm certainly not being disparaging about that, but I'm just highlighting it, just putting it on the record.
Okay. Correspondence. Can I refer members to correspondence in the main pack on page 262? There's an index at page 260. So some things just can I refer members to the correspondence from the Department at tab 1110, page 291, regarding Category 1 ambulance response times. I'm just wondering if members have any comments. Danny?
Yes, Chair. Category 1 ambulance call-outs are effectively cardiac arrests. Yeah. They're life-threatening call-outs, and I think the target's 8 minutes. The numbers are shocking. 47.9 response time in urban areas against 14.6 in rural areas in Northern Ireland. Like that is a truly frightening figure, that these targets are not being met at. Just to highlight, what is being done here in order to address this. I know the department has recently put in the Release to Rescue programme. I don't know if it's fully implemented across all trusts yet. I know that staff are very, very concerned about the impact that that's going to have on already overstretched A&E departments. But just to note concern at the time, or at the rates here, and the impact of that perceived programme.
And we had the issue the other day of the Royal College of Royal College of Emergency Medicine's report on excess deaths, and I mean certainly in that there was a bit of concern about the release to rescue scheme. I mean, all of these things are a balance, but it's certainly something that I think we need to keep an eye on, just to see how impactful, either positively or negatively, that it's having.
I also just make note as well that today the figures were released about A&E attendances, and compared to last year, A&E attendances breaching the 12-hour target. Now, the 12-hour target is something that should never happen. No patient should ever wait longer than 12 hours. And the patients who are waiting longer than 12 hours has increased by 14% year on year from this time last year. So, you know, the pressures in A&E are getting worse. Patients are waiting longer, and we know that that does lead to increased mortality.
There's definitely serious pressures within the system, there is no doubt in that. So, okay, we'll definitely keep an eye on that. Also, members, tab 1119, page 453, just mentioned it, state of emergency medicine here in the north. So I think it would be useful if we scheduled a briefing from the Royal College of Emergency Medicine, just in light of the report, if people are content.
Yeah.
Okay. Any other items that anybody wants to raise in terms of the index? No? Okay, so all the other actions will carry out. Any other business, Dan?
Well, it was about the RCEM.
Oh.
That's what it was.
Okay,
So that's fine.
fair enough. We're going to go into closed session unless you...
So a very quick issue. I was going to raise it whenever they were here, but to be honest, I think maybe it's more of a question for the Minister. It did come up. I think it was Nuala actually that raised it around the staffing issues and the skills, and you know, do we have enough people, and that's a big part of our problem. But I actually got an email this morning from a graduate physiotherapist who cannot get a full-time position because there hasn't been one single full-time position advertised within any of the health and social care trusts, unless you have experience. So no graduate has seen a job advertisement in any trust that they could apply for in the past year. That's out of 70 graduates. That's just physiotherapists. She said she's spoken to other health care professionals who are in the same position who are graduates. So we, on the one hand, we're saying we need to train all these people. We need them to stay here. We have absolutely no job for you as a new graduate, but we expect you to get experience. How? And we already know if they go somewhere else to get experience, they're not coming back here.
Yeah.
So
are
if
you
we
asking
can,
to write to the Minister?
Write to the Minister. I think I can forward the letter to yourself, Keith, but I think it's a committee issue. That's not a constituent issue. That is very much a committee issue in terms of...
Oh, I think we should write on the back of that letter and ask how many, just to confirm that is the scenario, and then what's he going to do about it.
And if they can confirm what, you know, in terms of other healthcare professions, what are the figures in terms of graduates jobs being advertised for those graduates within the trusts? Yep.
Okay.
I had one quick thing.
Go ahead, Danny.
I recently met with ADDNI, who are the ADHD charity in Northern Ireland, working with mostly young people. They had expressed concerns just about the Minister's needs assessment report for ADHD. It was released in February, I think, at a cost of 12 million attached to it. Now they're concerned that now they have a needs assessment report, that it's what the next step is. Where are we going about, you know, starting to implement this? Have we had a briefing on this? From memory, I think it's one of the committee's priorities. Is that correct? ADHD?
It was one of the committee priorities, and then we narrowed the priorities down to 4. Okay. So we did but it is something that we get regular updates on. Okay. I think you're right. We got the report through in February or March time, so we did.
And we're going to have a conversation of our priorities in closed session later on in this meeting. So
thank you.
Okay, so if members are content, I'm going to go into closed session just for the next item on our agenda.
Committee Room 29. Sound. Committee Room 29, Sound.